Hello, guys. Good evening to one more interesting session on this Sunday evening. Today, the talk would be on physical therapy management of functional GI disorders. Today, we have a very special guest with us, Dr. Deepti Guduru. She is a trained physiotherapist from SRMC Chennai. Following that, she has done MSCPT from Massachusetts General Hospital Institute of Health Sciences at Boston, USA. And to her credit, she has a lot of certifications and she specializes in pelvic rehabilitation and also some areas of interest for her are pelvic floor stimulation, biofeedback therapy, pelvic pain management, urinary incontinence, functional GI disorders, pelvic floor prolapse, and obstetric and gynecological physical therapy. So she has, to her credit, a lot of newer innovations and instruments that she has come up with, which she will be elucidating in due course to us. So thank you, ma'am, for accepting our invitation. She is the founder of Karuna Wellness and Rehabilitation Center. Thank you for accepting our invitation, ma'am. And the podium is yours. Most of our gastroenterologists are eagerly waiting for a topic like this, which generally doesn't get discussed because of its complexity, basically. So it's a privilege for us to have you here. The podium is yours, ma'am. We would want to utilize each minute of this particular talk to the greatest utilization possible. Just to give a brief timing, we would want it to be around 40 to 45 minutes, followed by 15 minutes of a Q&A session, where the Q&A session from the chat box would be try to answered as early as possible, and we would try to include as many questions that are included in the talk. Thank you, madam.
Thank you for that very kind introduction, Dr. Prashanth, and thank you for Ready Stock for giving me this opportunity. Like Dr. Prashanth was saying, it's a complex topic and not many people are aware of it. So I'm hoping that today I'll try to demystify it a little bit. So it'll be a little bit of anatomy, a little bit of physiology, and lots of physiotherapy. So I'm also going to show you physiotherapy techniques because that might be new to you guys. So there are a few extra slides, so bear with me. I'm hoping to make it interesting for all of you. So here goes. And the reason I name my slide Beyond Kegels, this is physical therapy management of functional disorders, is because that's the buzzword. Everybody thinks strengthen your pelvic floor, and the name given to it is Kegels. So our entire therapy, which I studied for 2 years, has been made into one exercise. So this is to show what else exists beyond Kegels in the scope. So the objectives of today's topic will be the understanding of the pelvic floor anatomy function, pathophysiology of dysfunction, practical assessment methods, and review the treatment options, which is exercises, biofeedback, and electrical stimulation. So this is my favorite slide. This is the anatomy of the pelvic floor. I wish I had my 3D module, but I think this also does the work. Is when you think pelvic floor, everybody just thinks about the levator ani. But the levator ani is actually a set of 3 muscles. It's the levator ani is the pubiococcygeus, puborectalis, and iliococcygeus, and posteriorly comes the coccygeus muscle also. And all of them are innervated by a branch of the pudendal nerve with nerve roots of S2, S3, and S4. What is very important about these muscles is all of them originate around the pelvic rami. So their origin is from the pubic symphysis, ischial body, and into the sacrum. And the coccygeus is the thicker muscle that also, though it is, sometimes it's called a part of the levator ani, sometimes it is not, but it's a thick muscle which contributes very greatly to the working of the levator ani. The only difference is S4 and S5 nerve roots. So sometimes in nerve root damage, this can be spared, or this is the only one which is affected. So it is either very helpful for us, or it is the one which is causing the most dysfunction. So going on to the next slide. So how a physiotherapist views the pelvic floor. So this, what I'm looking at my slide is the superficial muscles of the pelvic floor. So I'm looking at, of course, this is a female pelvis floor, female superficial pelvic floor, and we usually palpate with our finger. And with this finger, and the rectal examination also pretty much goes the same way, but this is the vaginal examination which I'm showing. So we insert the pad down and we look for the bulbocavernosus, ischiocavernosus, the fascia, the superficial transverse perineal muscle. Of course, we identify the superficial genitalia also, like the clitoris and the vestibule. But usually this is how much we go superficially. And then comes the deep pelvic floor. So when you're going deep in, that includes PR or PV, we are looking at the pubococcygeus and the obturator. All the way to the ischial spine comes the obturator internus, then the iliococcygeus, then the coccygeus. Piriformis, sometimes with dysfunction, you can find tenderness, and if you can dig way deep in, you can palpate the fascia of the piriformis also. And the last tightening, it feels like a band, that is the sacrococcygeus ligament. And we are very well trained to differentiate between the muscle and the ligament. So if the patient is willing, pubococcygeus ligament. We are trained to manipulate the coccyx also in treatments. So just lateral to it is we feel the ligament and we can go accordingly. Why palpation is so important to us? Though everything, when you go inside, everything looks like one muscle. But for us, when you're palpating layer by layer by layer, we understand where the puborectalis is, which is very important to us because you're trying to differentiate the sphincter from the rest of the levator ani. So when our functional disorders come, when you're looking to see whether it is a sphincter disorder versus a muscular disorder, we need to clearly differentiate. So that is why the palpation anatomy is very important. And there is another way to look at this. I mean, this looks, everything is pink and everything is soft. So there's another way to look at it is, and before I go there, talking pelvic floor physiology and anatomy, most importantly, what does the pelvic floor do? It is important for the continence and evacuation of the bladder bowel. It acts as a support, acts for stability. The lumbopelvic system is actually one of the most important biomechanical factors in the body, which provides support for the whole core. So the core is the abdomen, and the back, the spine muscle is the spinous process, and the spine bones are the ones which are thinking that you give posture, but it's actually the whole system with the pelvic floor together. So very, very important. Also acts like a sexual organ. So going again, it gives the organ support, bladder and bowel control, passing of urine and feces, sexual function, breathing, pregnancy, and childbirth. I'll be reiterating on breathing a lot because it's a very underknown fact that how much breathing affects the pelvic floor. And in this picture, I want everybody to notice that it is a sling muscle. The way it is positioned in the body is with a lot of tensegrity. Tensegrity is the word which we use because most of the muscles are vertical in the body, and this muscle alone is horizontal, other than the diaphragm. So the amount of weight it bears is based on the tone. So it is already carrying more tone than a normal muscle. And it has a lot of tensegrity because it contracts constantly. It is never in a supremely relaxed position. So that is something you have to keep in mind as we go ahead. So talking about the pelvic floor and the diaphragm, a lot of people think the abdomen comes out and the pelvic floor is, also going up. It's actually the reverse. Diaphragm, with every diaphragmatic movement, the pelvic floor also moves. So the diaphragm moves down. That is means when you're breathing in, the diaphragm moves down, abdomen moves out, and pelvic floor also moves out. So it's pretty much like a balloon. So if the exhalation is happening, so you breathe out, this goes up, this also goes up. So very, very simple. So, and in a breath hold, actually, so if you're holding your breath, you think that the abdomen is not moving, but actually the diaphragm has come down. So breath holding will put pressure on the pelvic floor to descend with the pelvic organs. And talking about pelvic floor dysfunction, I'm going to run through a bunch of slides a little fast. So most of the bladder symptoms are the urinary incontinence, bladder storage issues, sensory, voiding difficulties, lower urinary tract infection and prolapse. And coming to the bowel symptoms or the GI symptoms, anorectal incontinence, defecation difficulties, urgency, prolapse, and pain. But I'm going to divide them into three major causes, which are the dysfunction, which is obstruction, incontinence, and pain. So when we're talking about therapy, that's how I'm going to go. And what are the causes of dysfunction? And I'm talking about physical dysfunction and physiological dysfunction. So organic causes, you all are gastroenterologists, you know it better than me when it comes to organic causes. But pregnancy, childbirth, aging and menopause, excessive pressure on the pelvic floor. Believe it or not, Kapalabhati is our enemy. So a lot of people who say, I've been breathing so well, I do a lot of Kapalabhati. That's increased abdominal pressure unnecessary on the pelvic floor. So chronic cough, COPD, chronic constipation, straining, heavy lifting and straining, hard foot exercises like running, jumping, skip roping, weightlifting, they also damage the pelvic floor. Sometimes prostatectomy leads to dysfunction, frequent UTIs, inherited risk. There is a small familial risk that is documented, and the disease of any disease affecting the connective tissue, like a Marfan's, will also, because connective tissue affects the tensibility of the pelvic floor, and the whole complex goes in for a collapse. And we were talking about palpation before. So as a physical therapist, our evaluation when we do a PR, it is a little different than how a regular surgeon or a gastroenterology does it. So we are talking about, first, of course, we are going to do the Bristol stool scale and all of that, a diet diary and all of that. But when it comes to the pelvic floor, if you can see the clock up on the slide, that's how we view the pelvic floor. So you see the pubis on the top, right and left are the ischial tuberosities, and the tailbone in the bottom, which is the coccyx. So we call this the pelvic clock. So when I'm checking for pain or dysfunction or weakness, I mark it on a clock, saying that is it between 9 and 12, 9 and 6, 6 o'clock, and so on and so forth. So this gives me an idea which muscle am I talking about. It is kind of imprinted in our head, and when we are working for stimulation, we know exactly where to put our probe. And EMG will be coming ahead. And I'm sorry, that is the VAS scale. So we always check with pain. And when we palpate also, we check for tenderness and scale it from 0 to 10. And I'm skipping the slide. How do we know the pelvic floor strength? So coming to the strength of the pelvic floor is, like I said, it's not just contraction, it is the ability to maintain tone. So quick contractions are the ones which are needed for continence and sexual function. The ability to relax is the one which is needed for urination and defecation. And evaluating the strength of the pelvic floor is not as simple as assessing a single contraction. So one contraction will not give you a lot of information. You need to check for power, endurance, speed, and ability to relax. And I'm going to show you something which we learn in our undergraduate and postgraduate. So this is how we assess the pelvic floor. It seems like a lot, but I'm going to run you through it. Come down to a diagnosis. Like a doctor, like a gastroenterologist comes to a diagnosis of constipation or solitary rectal ulcer. You come down based on certain symptoms. We come down based on inspection, which we are looking at. Are we seeing a co-contraction? Are you seeing a regular contraction? Is relaxation visible? Other than that, we ask the patient to cough. When they're coughing, do we see the pelvic floor moving inwards or do we see the pelvic floor moving outwards? Then we do palpation at rest. So we are checking for pain and any tender points. Then we are doing palpation during movement. So we ask them to contract the pelvic floor and then we start looking at it. We look at the urethral lift, very, very important. There's something called the perineal body. I hope everybody knows this. I forgot to mention that all the origin is bony, but all the insertion of the pelvic floor is muscular. Everything inserts into the perineal body. That's why the perineal body is extremely important for us visually and while you're palpating to see the movement. That shows the insertion. So we know whether the muscle is working in its original length or not. Has it shortened or is it lengthened? So we are looking at symmetry also. Left to us is right. And we are looking at how much movement is happening laterally. The next one is we look for endurance. So when we ask them to contract and we ask them to hold also, 0 to 10 seconds. 10, of course, is very high, but we give them that choice and we palpate and we relax. It's not when the patient is relaxing, it's when you palpate and you realize the patient is thinking they're relaxing after 6 seconds, but they probably gave up after a second and a half. So you document that. And then you also look at level of relaxation after conscious contraction. So then do it multiple times and see when they're pushing also, when they're pulling inwards also. And when you do all of this put together, we come to a conclusion. The conclusion is whether the pelvic floor is overactive, the pelvic floor is underactive, the pelvic floor is normal or if the pelvic floor is uncoordinated. So this is how we go for it. And the last, there is one more which says a non-functional pelvic floor, which is pretty much not doing anything. Any commands are not being followed. And this doesn't mean there's a neurological disorder. It is just that it's a non-functional pelvic floor because there is some underlying dysfunction which is chronic. So when we document, this is very important because our treatment is completely based on the muscular function. So overactive, underactive, normal, or incoordinated pelvic floor. That's another version of the same thing. We document biofeedback. This is a form where we document for biofeedback, where we are looking at coughing, relaxation. And here we look at the nature of if there is any flatus also in, if there's any flatus or urinary incontinence, this is another form which we take that also into consideration and Valsalva. And going into a little more detail as to how we grade. It is not 1, 2, 3, 4, 5 grading. It is basically 1, 2, 3, 4, 5 with a modification. So no discernible contraction is a 0. 1 is a weak flicker contraction. 2 is a weak contraction, but perineal body movement is there. Grade 3 is a little stronger. 4, 5 is the full strength. So we document that. And we call it the perfector score. Perfector score is we look at power, endurance, how many repetitions, how fast can the person do the repetitions, the elevation of the perineal body, are there any co-contractions, the timing and relaxation. This could be seeming a little alien because this is not something which you see every day in your practice, but this is for our documentation. So when we see the documentation, the gastroenterologist also understands, okay, this is the level where the pelvic floor is right now. Now coming to the types of disorders which is in our scope of practice for physical therapy is functional fecal incontinence, functional anorectal pain. In the pain, you have the chronic proctalgias, levated ani syndrome, also known as myofascial trigger syndrome, and unspecified functional anorectal pain, and proctalgia fugax. And the last but not least, the ones we see the most are dyssynergic defecation and inadequate defecatory propulsion, also known as slow motility disorders also come under our purview. So this is again related to biofeedback. When we see a biofeedback or we do a rectal palpation and do our check, we understand when it comes to fecal incontinence, is there rectal hypersensitivity and pelvic floor muscle dysfunction, rectal hypersensitivity and pelvic floor underactivity, rectal hyposensitivity and overactivity, rectal hyposensitivity and pelvic floor function underactivity. This is what you also, the machine gives you as your biofeedback when you come as dyssynergia 1, but we classify it this way. Now, this is an algorithm which we were talking with Dr. Prashanth earlier, saying that we usually see them before they become chronic. So when the patient usually comes with anal incontinence, the GI refers to the colorectal or the gastroenterologist and sometimes refers to physiotherapy as well. So we do conservative therapy, and if conservative therapy fails, we refer back. Definitely. And I don't have to go into investigations because I think everybody is well versed, but definitely anorectal, the ultrasound scan, colonoscopy, MRIs, and such. So the goals, what are the goals of pelvic floor muscle training in anal incontinence are optimizing the stool consistency, normalizing the urge, normalizing frequency and defecation. And what does the pelvic floor muscle training do? It optimizes the exit, which is the puborectalis and the external anal sphincter. That is our job, and how we do it, we'll be going into detail. So also physiotherapy includes education. Very, very important. We do a lot of education, 1 to 2 hours of hammering how to manage your incontinence. So we do a lot of sociology and psychological evaluations and counseling, lifestyle modifications, diet and fluid modifications, defecatory dynamics, establishments of regular habits, pelvic floor muscle training, of course, rectal irrigation, we teach them. We teach them recovery time in supine and skin management. In my clinic, I even have the barrier creams, pads, and plugs and such, because sometimes the patient is more embarrassed than anything else. We teach them in the process of recovery, what are the various things you can use to manage your incontinence. So this is a small video I'll be playing. So this is another treatment technique we use for treating of the incontinence. This is, I'm sorry, this is the sacral nerve stimulation. This is something which seems experimental, but it is not. In the Western countries, they have the chip which they use. I think all the doctors must have seen or heard about it at some point, is the implanted chip. Here we don't implant it, we use external. So we are stimulating the S1, S2, S3 nerve roots, like we were talking before. So the pudendal nerve is being stimulated via electrical stimulation. We do that with the e-stim in our clinic. So here I'll be demonstrating the placement of the electrodes. So we do that with a lot of our incontinence patients as a part of regular therapy. It takes around 14 days to 21 days for them to start understanding the feeling. It's an adjunct therapy. We can't do it as standalone. And it depends on the chronicity also, how they respond. The sooner they come, definitely sacral nerve stimulation has a huge role to play in the treatment of fecal incontinence. And to give a quick summary of what we do in physical therapy is, we were talking before of optimizing stool consistency and optimizing the pelvic floor muscle as such, but also calming down the urge. We do a lot of mindfulness in rehab. So the urgency which they have, and they don't have the mental control to control the sphincter, and they run to the bathroom. We try to teach them that also. So calm down the urges and reduce the rectal sensitivity. So to reduce the sensitivity also, we use biofeedback. We use rectal balloons, biofeedback, pelvic floor muscle training. And we up train. So we'll be talking about this. We train the muscle up a lot. So we train in endurance and we train in strength also. And when it comes to stress incontinence, fecal incontinence, we up train and we talk about defecatory dynamics also. And when it comes to smearing, the patient has smearing, we teach them how to optimize the stool consistency. So firm up your stool. So dietary management, uptrain the pelvic floor muscle, and hygiene, how to maintain rectal hygiene. Now jumping to our next topic, which is functional constipation. So this are the other differential diagnosis: anismus, pelvic floor dyssynergia, obstructed defecation, paradoxical puborectalis contraction, non-relaxing puborectalis, pubic outlet obstruction, spastic pelvic floor syndrome. But believe it or not, I've even seen pelvic floor avulsion. They've sent avulsion and with dyssynergia, followed with dyssynergia. So that also, so it could be an injury or it could be chronic constipation, which is causing a tear in the muscular insertion. But all of it basically comes under dyssynergic defecation or slow colonic dysmotility or slow motility constipation. Now, characteristics of it, I'll run through this because I think nobody needs but it's just like a refresher for all of you. So there is a paradoxical external anal sphincter or puborectalis contractions, involuntary anal spasm or inadequate anal relaxation during defecation, inadequate puborectalis relaxation, impaired abdominal and rectal pushing forces. All together contribute towards dyssynergic defecation. Common symptoms: 84% excessive straining, 74% abdominal bloating, passage of hard stool. Other than that, less than 2 bowel movements per week, 62%. Digital maneuvers like disimpaction or splinting, feeling of incomplete evacuation, and difficulty in evacuation stools at 76%. Associated symptoms also are frequency, urgency in urinary function, sometimes dysuria, sometimes dyspareunia. We always check for that. We are not going into detail here, but low back pain with radiation into thighs or buttocks, and pelvic pain unrelated to intercourse. Other common findings, again coming back to biofeedback. Constipation would be an impaired balloon expulsion, decrease of straightening of the anorectal angle. This you see in the MRI defecography. Decreased descent of the pelvic floor with defecation, prolonged rectosigmoid transit times, lower intrarectal pressure, higher anal residual pressure, impaired rectal contraction, smooth muscle propulsion, paradoxical anal contraction, inadequate anal relaxation, blunted or absent rectosensory perception. Now, diabetes criteria for this, again, going through this is, I think, the most important I think this you will be more familiar with, where paradoxical contraction of external anal sphincter or puborectalis, limited perineal descent, less than 1 centimeters, impaired push. The perineal body should sit 2.5 centimeters above the ischial tuberosities. Normal descent is 1 centimeters. Less than 1 centimeter is indicating a paradoxical contraction. And in slow transit constipation, prolonged stool transit time. So that is the gold standard. So now I'll go through the same evaluation techniques. It's a little different. In this, the psychosocial status makes a huge impact compared to anal incontinence. Comorbid conditions, history of the onset, use of what medications and for how long. Then you have the amount of fluid intakes, bowel habits. Bowel diary is a must for all these patients. I do a 3-day or a 7-day bowel diary. And the presence of pain, trigger points in abdomen, trigger points in rectum and buttocks, very, very important, and associated urinary or sexual symptoms also. This is a last slide, but it's the same thing like before, but we have brought it all to a close. How does physical therapy assess it? Is the comorbidities, stool assessment, bowel and diet diary, the resting tone. So usually these are hypertonic pelvic floors. So what is the resting tone versus the normal hyper or hypoactive pelvic floor, estimated length of the anal canal. So if there is an MRI dorsography, that helps us. The perfect score, relaxation following contraction, pain, discomfort, EMG biofeedback. The rest of the ones are the biofeedback readings, which we'll be going through again. Now, why are the obstructive and structural constipation, what is the significance of this? When we see it in our clinic, we see them as rectal prolapse, sometimes mucosal intussusceptions, rectoceles, solitary rectal ulcers, an enterocele or a sigmoidocele, and a descending perineum syndrome. Now, what are the goals? Like we were talking about incontinence before, what are the goals for physiotherapy? Is optimize stool consistency again, normalize the urge, normalize the frequency, optimize the exit, address improvements in the muscle, proprioception, normalize the rectal sensation, manage the rectal capacity and compliance. Physiotherapy management for this is a very familiar picture to everybody, is the defecatory mechanism. We try to correct the defecatory mechanism. Might look very simple, but sometimes the patient has pelvic floor tightness and they can't get the optimal position. So we try to relax and release these muscles. We teach them proper toileting postures, pushing strategies, teach them manual perineum support if needed, abdominal massage, pelvic floor muscle rehabilitation. This slide basically tells about how the propulsion, which is a perfect defecation mechanism, is. I think I will skip this slide because most of you already know it. And how do we rehabilitate the muscle to perform a perfect defecatory mechanism is, like I said, if it is an overactive pelvic floor, we down train it. If it is an underactive pelvic floor, we up train it. We make it stronger. We re-educate the diaphragm and the pelvic floor. What is the overall success rate of all these maneuvers is 70 to 80%. That was the latest study which was done. I'll be happy to provide the evidence for it later. So when done all of this, so the transverse abdominis, so work on the abdomen, work on the diaphragm, work on proper posture, mechanics, all of this, when it's worked on, you see a 70 to 80% improvement in their symptoms. And what is the kind of muscle work that we are doing is scar mobilization and myofascial release, soft tissue mobilization, adherent, any rectal scar. So we can tell the difference between a functional tissue and a non-functional tissue. So how we mobilize the tissue around the rectum. And deep vaginal lacerations or episiotomies, post-surgical scars, myofascial pain, tender syndromes, and ultrasound is applied to a superficial scar, and therapeutic exercise. I'll go through it now. So one of the big arsenals we have in our arsenal is the abdominal massage. So when you're looking at constipation or any pain, we do something called an ILU. So it is called an I love you massage, but it is the shape of the colon. So I'll be demonstrating it a little lower. It is some people call it acupuncture, some people call it acupressure. The points, Chinese medicine has this, Ayurveda has it, and physiotherapy also has it. But for us, we specifically use the hand or a gun. We use the hand or a gun to give circular motion along the colon. So that's what we do. And this is one demonstration for it.
Dr. Deepti, you muted your voice.
Can you hear me now?
Yeah, we can hear you. We can hear you. The video doesn't have audio, right?
It does. I didn't realize that it did not have an audio. It did have an audio, but I think it was having trouble playing.
You can explain when it's happening, madam.
Yeah, I think I'll do that. So because you're not able to hear the video, right?
No, we aren't able to hear the video.
So the earlier slide was showing the usage of the massage and also the usage of the gun for slow transit constipation. And this is IFC, it is interferential therapy, which we use on 4 points in the colon. So this is a different kind of stimulations. For slow motility, it has shown a lot of benefits. Again, it has to be done anywhere between 14 to 21 days, and it shows a huge improvement because they start, the rectal sensitivity becomes, the abdominal sensitivity goes down, and the abdominal pain goes down, and it actually stimulates colonic movement. So it is the same current we use for a sports person while they're rehabbing. But in the case of slow motility constipation, these are the placements of the electrodes, and we use it for around 20 minutes on each patient.
Can you tell us what are the points you're using, ma'am?
So we use 2 of them just right under the diaphragmatic. So we use them around the umbilicus, like you can see it around the umbilicus, but 2 around the rib cage. So that is the just below the diaphragm, and 2 laterally and little lower to the umbilicus. So we are kind of mapping out most likely where the colon would be. And that's how we use it. Moving on to the next slide. So here we come to the fascia. We work a lot on the fascia in the clinic is because, and it's abdominal fascia, it could be deep pelvic fascia, is the target. I'm not going to go into detail in this, but I'm going to explain, is fascia envelops the whole body. So the concept is facial tightness in my neck can affect the facial tightness in my calf. So physical therapies or physical therapists, chiropractors, sports physicians, all these people work on fascia. So they believe in this cross-connecting network all over the body. So tightness somewhere is causing dysfunction somewhere else. And this is superficial. This is not an organic problem. This is more of a mechanical and structural problem. So we palpate the fascia all over the body, but here specifically, we palpate abdomen, pelvis, and inner thigh glutes. So we make sure there is tensegrity and there is a level of give. So there is not too much tightness in there. One thing you have to understand, it is poorly The vascular nature is very poor, but it is highly innervated. So the pain is more from fascia. So sometimes you think it's pelvic floor, but it's not a pelvic floor dysfunction. It is just the facial dysfunction. I will skip this. So these are the usual trigger points. Common functional myofascial trigger points is, like you can see around the clock. You can see the most common one would be around the pubic bone. Number 7 is where you see it. So it could be from the prostrate, it could be from abdominal pain, it could be from straining, but these are the myofascial trigger points. So we look at the superior levator ani, we look at the anterior levator ani, middle levator ani, coccygeus, sphincter ani, prostrate area, piriformis, obturator externus, and the coccygeal area. So we palpate around the pelvic floor. Another big culprit Another big culprit is the sciatic nerve, which can get entrapped at the layer of the obturator internus and the piriformis. So the pain which comes or perceived as a rectal pain could be a sciatic pain. Doesn't have to be an orthopedician's purview. The gastroenterologist can also try to move the hip a little bit and see if there's tightness in it and recreating the same pain. And these are the dermatomal patterns of pain. So in case there is a nerve issue, so any nerve root coming from the sacral plexus, these are the dermatomes. We check a little more gross, but if you're suspecting a nerve injury causing any pelvic floor dysfunction, we will go in detail and map out all the dermatomes. And this is the referred point of pain. So it doesn't have to be only rectal or abdominal pain. Rectal pain and abdominal pain are the most common ones, but like you can see up to the left corner is the trigger points, like we were talking about. So the same trigger points can spread into the gluteus, can spread into obturator externus, can spread into the abductor, gluteus maximus. It can spread into the sacroiliac joints. So we go outwards to inwards. So when we are treating the patients, we start from all the trigger points which are outwards and work our way inwards. And now coming to the modalities we use for all of this is definitely ice, heat, ultrasound, electrical stimulation, TENS, and the intramuscular stimulation we were talking about, and neural stimulation and stretching. I will skip this. So this is one of the modalities used in my clinic. Here we're showing intravaginally, but also intrarectally. I didn't have the picture for it. So on my left side is the person doing a diaphragmatic release. So a tight diaphragm. So pelvic floor is not moving. So it's a given that the diaphragm is also not functioning well. So we go in manually and we release the diaphragm. And after releasing the diaphragm, then we go into the pelvic floor and we do a manual release. The person down is using something. We use our finger, but there is also a wand. It's called a pelvic wand. That also can be used for myofascial release. And here we're demonstrating few of the exercises we do. Few of the exercises we do for stretches. These are the stretches which everybody has to do in our clinic. Because we're running a little short on time, I'm running a little behind. So I'm going to go into biofeedback. But before that, this is acupuncture needle. We call it dry needling or also electrical stimulation. We use this directly on the pelvic floor muscles to stimulate them. And the the electrical stimulation is not very well tolerated by a lot of people, but the dry needling is tolerated quite well. So if we see a myofascial trigger point, or we are seeing, tightness around, and what is usually, before they go in for a surgery, like a sphincterectomy, I would suggest highly try this, because this releases the muscles around, and you see an improvement in the movement of the sphincter as is. So we do this for the neck muscles, shoulder muscles, we do this for facial muscles. So we do the same thing for the pelvic floor muscle. And these are dilators, which we use regularly, also for stretching and for relaxation. And to the right are cupping. So to increase blood flow to the perineum, we use cups, vacuum cups. And on top is the pelvic wand. And now I'm skipping where we are teaching you breathing exercises, because I want to focus on biofeedback. So this is one of our treatment techniques. So this is an electrical stimulator with the vaginal probe and the rectal probe. This electrical stimulator can give two types of current. It can give transcutaneous electrical nerve stimulation, and it can also give electrical stimulation. So it can be utilized for pain, and it can be utilized for uptraining the pelvic floor also. So the stimulation we were talking about on the abdomen can also be done with the same machine. And these are the details of the parameters, but we can talk about that later. It's not of consequence here. So what is important is that we are working with two types of fibers. So when we are up training the pelvic floor or down training and using biofeedback, we need to know whether we are doing the slow twitch fiber, which is the endurance fiber, or the fast twitch fiber. So what are the types of biofeedback a physical therapist does is surface EMG, but also internal EMG, and even something as simple as a vaginal weight or an anal plug. All of this together is called biofeedback. But here I'll be specifically talking about electrical biofeedback. What is the electrical biofeedback? Is an adjunct to pelvic floor. All of this pelvic floor muscle training we did is on one side, biofeedback is on the other side. So this reinforces our treatment. All of that treatment which we did is reinforced to indicate the activity of pelvic floor muscle in real time. It aims to improve teaching of the adequate contraction techniques and affects motivating the patients to adhere into the muscle exercises we are talking about. So the type EMG you also have. So these are the two types of EMGs which we use is pressure EMG or electrical EMG. So there's a lot of crosstalk. There is a lot of artifact. That means which is not the right movement. So a trained biofeedback technician or a trained biofeedback physiotherapist or a doctor is the only person qualified to do this. Otherwise, you're catching information from everywhere else and your reading becomes nullified. You're not getting the right reading. So, like I said before, very important that the same therapist or the same doctor is the one sitting and assessing the patient every single time. And to talk about, so this is the screen. So this is how an electrical biofeedback looks like. So the first few flicks which you see is muscle activity as such. So then you go in to train a patient to contract and relax. And then if you want to check endurance, you ask them to hold. So the pattern of the EMG changes according to your instruction. So this is another slide which shows to the left are two groups which were pelvic floor with pelvic floor dysfunction. You can see the shape, most importantly, the shape of the biofeedback result is there are a lot more flicks. Whereas on the right side, you can see it is more even. It comes to relaxation completely at the same pattern every single time. And the bottom, number C, you can see a lot more flicks and no relaxation. So this is a pelvic floor which is very, very tight. You can just look at it and tell. And whereas number D is after few sessions of treatment where there is enough relaxation. So contraction, relaxation, both are voluntary in this patient. So when you look at a repeat manometry result, so that was the electrical biofeedback. This is your manometry. So after treatment, you're going to see increased intrarectal pressure and coordination and relaxation of the anal sphincter. That is how your, so number C, number 1A would be pre-treatment and C would be post-treatment if you want to repeat a manometry. So when you give biofeedback therapy, this is by Rao et al. And I had the privilege to actually meet Dr. Rao once. So bi-weekly biofeedbacks at least 2 to 3 times. You do it for 6 weeks, 60 minutes each at least. And you do home exercise therapy for 20 minutes, maintain a stool diary and laxatives according to your gastroenterologist. And you slowly wean off from the laxative. Who are the people we don't do therapy for in pregnancy, menstruation, biofeedback? We don't do these for these patients with severe urge incontinence or a prolapse which is greater than grade 2, positive pregnancy test, painful hemorrhoids, fistula or a fissure. And in conclusion, pelvic floor muscle training is not the only thing. We also have to do biofeedback with the pelvic floor muscle training for incontinence and for pain and for this. So we are trying to involve the patient in their own care, increase their sense of control, help them manage their symptoms. And there's a lot of studies which show that all of them put together, biopsychosocial factors are the best way to treat these patients. So that's our presentation today. Thank you. I think I went over my time by about 5 minutes. So I'm happy to take any questions now.
Thank you, ma'am. A wonderful overall session with so much information. So more like an anatomy we had to see. For us, we are more luminal. Intraluminal, we would know what's happening. But then from a muscular perspective, there are so many things that are happening, and it's not a single muscle. It's a group of muscles functioning together as a unit, and what all it can go do is an important concept which you have brought out. So, and the different modalities of treatment, what all are available, and when to actually refer a patient. You had specifically mentioned when you get a patient at an early stage, the chances of cure is better. What do you mean early stage, and what do you mean as late stage?
So early stage, when you're taking history, and the patient gives the history of incomplete evacuation, history of sense of urgency, history with a sense that I feel like I am trying to defecate, but something is stuck there, it is not coming out. And instead of putting on a laxative, with the laxative, if you refer physiotherapy, along with the laxative, most likely would be a pelvic floor issue. So then they respond very well within 3 months, 6 months also. But 10 years of taking a laxative, and then some very nice doctor has referred a manometry, and then dyssynergia comes out, and then they come to physiotherapy, the muscle is already quite stretched out. So the amount of work we can do on that muscle is a little less. We still can try, but the efficacy of treatment is lesser.
Okay, cool. So, a second, you mentioned about breathing. Most of us explain about breathing, especially from the second session onwards when they come for constipation, manometric biofeedback therapy. When we do, first is about anal relaxation. Then it will be about breathing and improve the rectal pressures, and then comes the push and coordination. So, uh, understanding of diaphragmatic breathing may be a little different. When we say a patient, it's simply like you have to keep your hand on the abdomen and inspire and expire and make sure it goes out and in respectively. So then actually when they push, it is like Valsalvas where they actually hold it and try to push it down, where the anterior muscles in down actually comes front and pushes it, the does the pushing movement.
Pressure.
Yeah, pressure. So we want it from you, madam. You tell us, explain to us, what would you tell when you're explaining about breathing? And also, there was a video on breathing where which was skipped. I think if you actually play it, it would be more informative
Okay.
for us.
I think actually I wanted to play that. So our breathing is very different. We actually disagree with abdominal breathing because abdominal breathing pattern reinforces bad behavior. So like you said, Valsalva, they're doing Valsalva. They're not increasing intra-abdominal push. What they So this is the breathing one. So in the first one, she will be demonstrating a diaphragmatic breathing. So now we've established so many times that when you're doing breathing, the diaphragm is the one which has to move. So she's breathing in with her nose, breathing out with her mouth. So to reinforce that, we place hands on the chest, not the abdomen. We place the hands on the chest, and when you breathe in, you move your chest out. So when you're moving the chest out, diaphragm comes in, pelvic floor is moving. So if pelvic floor moves, intrarectal pressure is better. It's nothing to do with the abdomen. Abdomen moves out automatically. So reinforce, as a doctor, please reinforce that the chest has to move more. So sometimes they have a reverse breathing pattern. Abdomen will be going outwards when they're breathing out. So for that training, we say put one on the hand, one on the abdomen. When you're breathing in, both have to come out. And when you're breathing out, both have to go in. So that automatically is giving the same movement to the pelvic floor. Another one which we show is we expand the thorax. So what she's doing is thoracic breathing. So she's breathing along with lateral movement. So this improves movement of the entire abdominal and pelvic organs. All the organs also move up because the abdomen is moving up. So this also kind of gives a gentle massage to the organs overall. So you're pulling them up, you're bringing them down. You're pulling them up, you're bringing them down. So we incorporate breathing into all our activities. So if they're doing squats also, we do breathing. You breathe in, and when you're going up, you breathe out. So when you're doing the exercises also, breathing in, breathing out. That's it.
Okay. So that's what we call it breathing, and it's an easy thing. But then what really happens is there's so much concept to it also. Like we always, when we explain, we tell don't breathe with chest, try to breathe with abdomen, where when you abdomen breathing will help the pelvic uh, muscles. So that's one thing. So second is when you were also telling that Kapalabhati actually worsens the uh, pelvic floor, or maybe it strengthens it more. So what exactly did you mean by that, madam?
So when I'm not a yoga practitioner, I have nothing against yoga, but pranayama is what we do. So in and out, perfectly fine. Anulom, Vilom, that's the name. But when you do Kapalbhati, which is forced exhalation, and it is forced exhalation, and they insist that you bring your breath out all the way from your belly to outwards. So it puts a lot of strain on your pelvic floor. So it is creating unnecessary downward pressure onto the pelvic floor. So you're not strengthening. In turn, what you're doing is you're weakening the pelvic floor. So if you have incoordination issues, they become more incoordinated. If you're having incontinence, the incontinence becomes more. If you're having a prolapse, prolapse is descending even more. So that is the one exercise I always check with people doing yoga, saying that please stop Kapalabhati for now. No forced exhalation. There's too much pressure on the pelvic floor. Gentle, deep pranayama is much better.
Okay. It's basically to understand what exactly is happening against. Nothing wrong about, we are not against any sciences. Here, it's like some patients do come when we just tell them about diaphragmatic breathing. They already tell we are doing yoga, is already there, and they explain few terminologies. So we should just make sure that what they are doing is not against what we are trying to tell them.
Tell them.
That's more important. Second, EMG based biofeedback therapy. When you guys are actually doing it, can you just explain about the catheters? Like, do you implant the electrode somewhere and see the
Yes.
readings and then tell them like what exactly is happening, madam?
So I'm glad we spoke about that. So our probes, so we can do a balloon also. Balloon is also biofeedback. We can do an intrarectal probe, which looks like this. That's the one is the intravaginal probe, the other is the intrarectal probe. So they have two electrodes, the intrarectal electrodes. There are two of them which catch the levator ani overall and also the external sphincter. So we are calculating the electrical biofeedback. So the pressures are being measured in amps, milliamps. So when we see it on the screen, we see it as, like you can see that lady over there. So you can either see it on the small machine, or you can share it on a screen, or you can transfer it onto a see it. Sometimes we use it as a game. So when you ask them to squeeze, the pressure can be converted to see, like I have one in my clinic, which is like a rabbit. So when they're squeezing, the rabbit is running up and it tries to catch a carrot. So till it is catching the carrot, the patient should be moving. So it is a nice visual biofeedback for the patient, because half the time they don't understand. So till 1, 2, 3, 4 sessions, they don't understand what they're doing. So it is very important for us to explain and demonstrate to the patient that this is the correct movement. Please don't push, and reinforcement over and over again till you see the graph, which looks like this.
Don't
This
you
is the
put the electrode in the perineal nerve, ma'am?
we don't put it on the nerve. We put one electrode to catch artifacts on the thigh, and then we put the other. So this is not surface EMG. I'm talking about intrarectal EMG. So we put the electrode into the rectum. So we are catching the sphincter also, and we are catching the perineal muscles also.
Which your patient do you select? Dyssynergia 1, 2, 3, 4 for your
All of them.
biofeedback?
All of them. All of them. 4 definitely shows a little lesser improvement, but 1, 2, 3 are good patients to be sending, because the same biofeedback can also be used for stimulation. So if you're seeing that this patient has a sphincter problem versus a anal problem, so I'm sorry, a sphincter problem versus a rectal problem, you can stimulate directly using the same machine, but with a different setting. You have a different setting, or you can use a different machine. So you stimulate first and then do biofeedback. Because if you're doing biofeedback, let's say on dyssynergia 1 right away, you're just reinforcing the dyssynergia. The patient absolutely cannot modify his movement on day 1. So then you can either stimulate the muscles on the side and then stimulate inside, or just stimulate inside and say for 3 days and say, let us try biofeedback one more time. So they work hand in hand.
For each therapy is different from when you do type 1, type 2, type 3, the therapy is different.
Yes, the physiotherapy will be different because sensitivity and the muscle in coordination is very different.
What is the duration of your therapy, ma'am?
We take around 45 minutes to an hour with every patient, because we incorporate all the modules. Stimulation takes about 20 minutes. Biofeedback takes about 10 to 15 minutes. Rest of it goes into breathing and muscle work.
So when you say a biofeedback, do you have a session with the rectum and the anal sphincter together, or only you concentrate on anal sphincter, ma'am?
We concentrate mostly on the anal sphincter because that's where the muscle is. Rectal pressures, unfortunately, with our machines, we are not able to access the rectal area. That is more with your manometry biofeedback. They are more efficient when you do that. We can only access, because ours is an electrical biofeedback, we work only with the external muscles.
So what has been your experience, ma'am? Could you tell about your experience, which would be a better thing to do it?
Both I think are equally good if they have trained technicians. That the problem becomes when they're doing balloon expulsion, for example, and the conclusion says balloon not expelled in a minute or 4 minutes. It also depends on how the instruction was given, whether the patient was relaxed or not. But when we are doing rectal stimulation, this patient automatically is expelling the uh, balloon, or he's automatically able to expel stool. But sometimes what happens is we are not able to measure rectal pressures with our biofeedback, and the patient is unnecessarily going to the bathroom multiple times because he's hypersensitive in the rectum. So it depends from patient to patient, honestly. But both biofeedbacks, any version of biofeedback definitely works. With the history has to be taken well. This, it is more of a psychological thing also. Sometimes you have to remove the psychological aspect from the actual organic cause.
Okay.
And about the training, you said, madam, how much duration you expect the training should be, ma'am, for the physiotherapist? That's very important question.
Yes.
We wanted to know, so that there are a lot of physiotherapists who are keen and interested in learning about this techniques. Is there any duration you expect that the trainers require?
Well, I took 2 years, but I don't think that was my study of interest. But I think at least a week, a workshop of training. More than anything, they need to understand the kinds of dyssynergia. So about a week, 5 days to 7 days, if the therapist can be on hand, observe somebody doing this, or even an intensive 2-day workshop. If they can understand basic anatomy and where to put the probe, rest of it is the same thing we do in musculoskeletal sports, and they learn as they go. So the interest has to be there and the empathy has to be there. Those are the two very main important things: interest and empathy to deal with these patients, because they're tough patients. They're quite the condition is redundant, so they keep coming back to us over and over again.
Thank you, ma'am. Thank
Absolutely.
you.
You really told and very important information. The lack of therapists in this particular area with the appropriate expertise is more of a problem. So if we have more guys and girls who are able to help us out with managing these kind of difficult patients, chronic patients, it would make a great clinical impact in overall recovery. So the time is almost up, but then there was one question, there was one more word which you mentioned, ma'am. I'll just take one more minute.
Yes.
There was one mention about rectal irrigation. Like, where exactly do you do it? Like, for us, manual maneuvers are done by patient themselves with a faucet when the constipation or the exit issue is really a problem. So is it done as a part of therapy, or to train them from sensory perspective? What exactly is where do you use it?
Yes, so you were right. We do it as a part of therapy. We use enemas in the clinic. So this is the days where we are training them to wean off the laxative, or these patients are quite confused. They don't understand how to answer the nature call. They don't understand what means incontinence, what means they're always stressed out. And, so for these people, when we do an enema, I do it in the clinic. So we do it 2 or 3 sessions, in a week. So we tell them that this is how it feels. But I don't want them to get used to it. But we do it in the clinic itself. And we empower the patient to understand what emptying a bowel is, and what we have 6 bathrooms in my clinic. I have 6 bathrooms, and I keep telling them, please don't use it, only when needed. So the patient is trained in the clinic.
Okay.
Dr. Prashanth, I have answer for that. We have an equipment called Peristin. Peristin is an irrigation system which we can give it to the patient in their home,
Yeah.
which they can use it, and it's a very useful thing. Dr. Uday Ghoshal is using for his patients, and few other doctors are also using. So they recommend this Peristin equipment for the patient, where they can take it to the home, where there's a rectal probe. They can fill the rectum with the known amount of volume, with a known pressure, and they can use this. This is a Peristin, a very useful thing, and it's very cheap also.
Okay, cool. So a lot of information. So I think it'll take a long time for most of our gastros to digest each aspect of it. And definitely we will be coming up more with Madam for more nuanced topic inside this pelvic floor, like identification of which muscle, what exactly. Because recently I had a patient who was diagnosed to have incomplete evacuation, dyssynergia. But the moment he initially came a month ago, I just told him orally, these are the exercises you should be doing, and come back even without anything. And the moment he came here, and he finally decided, "Sir, I have incomplete evacuation. Please help me out. You do start the biofeedback." The first therapy, because the first session I hadn't done diagnosing it, he was able to pass the balloon within 10 seconds. So just knowing and doing few things, he was able to get the balloon out with just some uh, exercises that I had taught about relaxation and breathing and correct posturing. But he had the sensation clearly that there is something obstructed. Maybe is there something up above the anal sphincter level. So what he was talking about, maybe at the puborectalis level, where he really feels something is just not coming
Right.
out. He was very clear, but from my perspective, the manometry was perfect now. So I didn't have an answer. So always there will be answers coming up. Maybe he was trying to mean a hypersensitive puborectalis, which he's clearly able
Non-relaxed.
to sense it, but I am unable to from the equipment that I have. So there's so much to know. Definitely, we'll come back to you, madam. Your talk was interesting, and maybe we would have a further, more detailed talk, and probably we'll have more physiotherapists coming, getting trained, and maybe go distribute themselves to different parts of the country, help most of the gastroenterologists around at different places, so that ultimately it does good to the society also. Thank you.
Dr.
Thank you so
Prashanth,
much.
I would
Thank
like
you
to
for
add
the
one thing.
opportunity.
Dr. Deepti has a jadoo hand. where she can treat any, even a person is not able to expel anything, he will expel.
Oh, no, you're being very, very kind. So please don't send me all the chronic cases.
Okay, ma'am. Sure.
Thank you.
Thank you
Thank you,
for
Dr.
accepting the
Deepti.
Thank you
invitation in
so
such
much.
short notice. It was something which we all learnt a lot. We will get back to you for some more details, and maybe more people would want to get trained under you and at least see what's happening, what's the science, what's happening there inside, because not something which is generally spoken about or thought about. Sports injury rehabilitation, yes, we can see the muscle superficially. These are all internal things, so needs more expertise and demonstration, learning, conceptualization, maybe a longer learning curve. So we really are proud that we have an expert around us, and definitely we'll get back to you, and I'm sure that you would be giving us more talks like this. Thank you, madam.
Looking forward to come back. Thank you.
Thank you. Thank
Have
you.
a good evening.
Thank you. And thank you. And I thank Reddy Stock sir to really get such expert talks to our podium. Thank you, sir. Thank you, Jay, and thank you, Narayan sir.